do the intro, and then we'll go from there.
Perfect. And as you know, I can't see you, so the only cues I'm going to get from you are if you say them.
I will say them.
Perfect.
Good morning, everyone. Welcome to Grand Rounds. It's my great pleasure to introduce our speaker today, Dr. Daniel Sweeney. Dr. Sweeney received his MD degree from the University of Texas Southwestern Medical School in Dallas. He then completed his medical internship and residency at Albert Einstein College of Medicine in the Bronx. He pursued an infectious diseases fellowship at Johns Hopkins and a critical care fellowship at the National Institute of Health. We were fortunate to recruit Dr. Sweeney to UCSD, where he currently serves as the medical director for the Medical Intensive Care Unit. He is an associate clinical professor in the Division of Pulmonary Critical Care and Sleep Medicine. On a personal note, we're really lucky to have him as the course director for our internal medicine residency ultrasound curriculum. Dr. Sweeney is the UCSD site PI for the Adaptive COVID-19 Treatment Trials, an NIAID-sponsored multinational randomized control clinical trial where multiple interventions can be tested in series, building on successful treatments. We're really fortunate to have him here today to present Medicine Grand Rounds. Thank you, Dr. Sweeney.
Thank you, Sim. Can I advance my slides now?
Please do.
All right, here we go. So again, Sim, thank you very much for the overly kind introduction, and really thank you for this opportunity. Before I begin, I just should want everyone to know the flag behind me is not meant to be a political statement. I simply like it. POCUS has been a passion of mine since I was a fellow, and this Grand Rounds affords me the opportunity to show how this technology is integral to how I practice critical care. Just going to move something aside. Yeah. And again, I hope these Grand Rounds prove to be a tour de force, not for me, but for the utility of POCUS to systematically guide the diagnosis and management of the critically ill patient. And depending upon the quality of my Zoom connection, what I'm showing you in this picture is actually hepatic. Okay, is actually hepatic portal vein gas. So this outline is probably more for me than it is for anyone watching. I'm going to go over the current state of the physical exam, how I use POCUS for clinical diagnosis, how POCUS can be used for clinical management, how I integrate POCUS, and borrowing from our military friends with this notion of best line up front, I thought I would do the same and say it's important. My take-home message is it's important to integrate serial ultrasound findings across organ systems to fully understand and manage the critically ill patient. With the integrated multi-system point of care ultrasound exam, I believe it improves the clinician's ability to diagnose and manage a critically ill patient. I want to be clear, it doesn't replace the physical exam, and it doesn't replace the need for other imaging exams. And ultimately, I simply cannot imagine managing a critically ill patient without this skill. I have no financial disclosures. I do have conflicts of interest to share. To begin with, I've developed a passion for fruit trees and the fruit that come with them. Of course, my beloved Red Sox. And finally, I've become quite interested in learning how to make a good cup of coffee. Here's my eureka moment from 2008. I was a fellow, and this is an absolute true story. This is the first time I actually took the ultrasound machine to the bedside when I was called to a rapid response. And I think back in 2008, we called them rapid responses. And this is what I saw. And to sort of paraphrase one of my baseball coaches when I was growing up, and came out to the mound, and there were runners on base. He looked at me and he said, "Sweeney, you've got to get good, and you've got to get good real quick." And that was sort of my approach to this bedside ultrasound. I thought to myself, there's no way I could have managed this patient properly throughout the night if I didn't have this additional piece of information. And in case you're wondering, this is a clot in transition. I never saw one again for another 10 years. So I want to start with the state of the physical exam. And I don't want these next slides to sound overly critical of the physical exam. Rather, I simply want to highlight the challenges. And as a reminder, I consider the bedside ultrasound as an extension of my physical exam, not a replacement. So throughout history, we've had these master bedside diagnosticians, beginning with René Laennec, who invented the stethoscope. There was William Osler, essentially the father of North American medicine. More recently, Abraham Verghese, the prolific writer and infectious disease doctor at Stanford, who has really, I think, brought more attention to the importance of the physical exam. And there's Marty Cohen in the Bronx, who taught me basically all that I know about examining the heart at the bedside without ultrasound. But despite the work of these masters, physical exam skills remain elusive to many trainees. And I don't mean to discourage anyone from becoming a cardiology fellow, but using your stethoscope is a skill. It's a skill that needs to be refined, and it's ultimately remains a challenge for many people. Similar to heart sounds, assessing neck veins to estimate CVP is also challenging. This, I believe, is the first, well, I know it's the first, and I believe it's the only prospective study assessing neck vein examination for detection of elevated CVP in acute heart failure. 200 patients were evaluated by emergency department physicians, and patients were placed into 3 categories: those with normal neck veins, those who had prominent or had a positive hepatojugular reflex, and those who simply had JVD at rest. And the results of this were rather surprising. And essentially what they found was the neck vein exam was not associated with CVP. Higher body weight was associated with a lower likelihood of documentation of abnormal neck veins. But unfortunately, higher body weight was also a predictor, ultimately, of higher CVP levels. Going a little bit old school here, again, looking at a study from 1989, looking at the reliability of physical exam science to estimate hemodynamics in chronic heart failure. This was a study looking at 50 patients. They focused on 3 physical exam findings: Rales, edema, and elevated JVP. All patients after this exam underwent pulmonary artery catheterization. And what they found was, disappointingly, all 3 signs were absent in almost 50% of the patients who clearly had elevated CVP or elevated left end diastolic pressure. Again, extending this to peripheral edema. I hear about peripheral edema all the time on rounds in the ICU, and I worry, or I basically have to put that in the back of my mind and think about other physical exam findings. Here was a study of about 150 hemodialysis patients. They performed multivariate analysis, and what they found in these patients was that peripheral edema was associated with age, obesity, and hypertrophy. However, it did not correlate with proBNP, right or left atrial pressure, or relative blood volume. And unfortunately, there aren't other tools that are rushing through the door, so to speak, to help us out. Many of the other tools we use to assess fluid status in the ICU also suffer from limitations, including chest X-ray, natriuretic peptides, CVP, which is not always available in the ICU, and the same goes for the Swan-Ganz catheter. So let me begin at this point and discuss how I believe POCUS can play a prominent role in the diagnosis and differentiation of the critically ill patient. So there are multiple published ultrasound protocols for assessing the patient with undifferentiated shock. While none of these protocols have been compared head to head, I believe it's important for everyone to take a systematic approach, and that's what these protocols really emphasize. Each of these protocols, it should be noted, combine many of the same core elements, differing mainly in the priority of the exam sequence. So I think this case is a very common one that I see and really demonstrates the utility of POCUS in almost my daily activity in the ICU when I'm presented with a patient with undifferentiated shock. So this was a 66-year-old man with a vague history of pulmonary fibrosis. He presented with progressive dyspnea. His ED course was notable for lactic acidosis. He received steroids. He was admitted to the general ward. Shortly thereafter, a rapid response was called secondary to worsening dyspnea and now hypotension. Here's what the chest X-ray looked like. And here's the bedside ultrasound. And the first thing I would like to draw your attention to is the dilated RV, the pericardial effusion, the large right atrium, the prominent coronary sinus. All of these things are consistent with pulmonary hypertension or high right-sided pressures and not sepsis. Taking a parasternal short view of that heart for emphasis, again, dilated RV, the compressed LV or the D sign, and again, that pesky peripheral or pericardial effusion. So for emphasis, not all cases of shock and lactic acidosis are sepsis, and I really think that bedside ultrasound can be quite useful early in the management or diagnosis of these patients. Why is this? In part because there are so many sepsis mimics out there. This slide is intentionally complicated to really emphasize that point. And again, lactic acid really has not proven to be terribly helpful in these situations where there are many explanations or causes of lactic acidosis that I, again, show here on this busy slide. So everyone's familiar with the Wheel-Shubin classification of shock. And when most clinicians think about using POCUS for a patient with undifferentiated shock, they immediately consider the IVC size and collapsibility. And while I think that's important, I think it's equally, if not more important, to consider all of the other ultrasound findings that can be used to help differentiate these various causes of septic shock. And again, with the emphasis on the word integrate, integrating these other ultrasound findings along with the IVC, along with your physical exam to help make a diagnosis. So, and speaking of sepsis, point of care ultrasound has the potential to aid in the identification of an infectious source when you do have a patient with sepsis. This was a nice study of 200 consecutive patients who were given a diagnosis of sepsis. The study design was as follows. They had emergency medicine physicians perform a standard clinical assessment, history and physical exam, basic laboratory testing, and ask them to predict where the source of infection was. And then they compared that prediction with those same doctors after they added a POCUS exam to that same patient. The result, the clinical diagnostic accuracy for an infectious source improved from roughly 50% to 75%. There are limitations to the study. It was not randomized, and I really need to note these were highly, highly trained physicians. Some of the diagnoses made by these ED physicians with ultrasound included appendicitis. Here's another case, a 56-year-old man with a past medical history of alcohol abuse presented with increasing abdominal girth. CT of the abdomen showed free air. Patient underwent a laparotomy with resection of ischemic bowel. On post-op day 5, the patient really isn't getting better. A CT shows some mild fluid in the abdomen. Nobody seems to be terribly excited at this point. On day 8, again, the patient is no better. In fact, is probably worse, and they're still on pip/tazo. So a bedside ultrasound is performed. What you should appreciate here are complicated ascites. So the fluid overlying the bowel, loops of bowel, is not perfectly black. Instead, you can actually see fibrous material. So the suspicion at this point is this infected acidic fluid? So I performed a little bit more than simply a diagnostic paracentesis. Being interested in ID, I brought the fluid to the micro lab and had the technician make a slide. And this is me putting my iPhone up to the eyepiece of that microscope. And this is for our ID folk. I was actually able to see budding yeast under the microscope on that fluid. And of course, that resulted in the patient going to the OR in a much faster course. Another case, 82-year-old who presented with fever, leukocytosis, and shock. In this case, we were performing an ultrasound to identify possible causes of shock, and we performed a subcostal view of the heart, looking to see if we were dealing with cardiogenic, if there was a cardiogenic component. And then at this point, you can't unsee, even though you have a hyperdynamic heart, you simply can't unsee this large fluid collection in the liver, which resulted in a CT being ordered and a trip to IR to drain a liver abscess. Turning our attention to the lungs, ultrasound looking for B lines in particular can be crucial to determining the cause of a patient's critical illness. So B lines are these hyperechoic lines that originate from the pleural line, extend to the bottom of the screen. The physics of these B lines are not fully understood, and certainly not understood by a former history major. They clinically correlate with the thickening of the intralobular septae and or alveolar fluid. And to remind everyone, the intralobular septae contains lymphatics, veins, and connective tissue. In this classic ultrasound study, ultrasound exams were compared with CTs performed on the same patient. And what I'm showing you are three different patients. One is a normal patient with just an occasional B line. The middle column are showing B lines that are widely separated, consistent with thickening of the intralobular septae. For those of us who remember, think curly B lines on a chest X-ray. And then the last image is showing when the pathology goes on to involve the alveoli, and these B lines are much closer spaced. So there are more and more published reports highlighting the utility of POCUS to identify pneumonia. The three most common ultrasound findings that are documented in the literature include the B lines I've already mentioned, something called dynamic air bronchograms, which may not project well, but what I'm showing you are air and mucus-filled bronchi that are visible because they're surrounded by consolidated lung. And then finally, the shred sign, which is that irregular hyperechoic line that you see, jagged line running through the lung parenchyma. So let's look at a case where POCUS was used to differentiate pneumonia from fluid overload. This was an 85-year-old patient with hypertension, diabetes, presenting with syncope, melanic stools, and given a working diagnosis of a GI bleed. They received multiple blood cell transfusions, and eventually they were 5 liters positive. The next day, they were transferred to the ICU with respiratory distress and concern for fluid overload. Here you see the chest X-ray worsening over this hospital course, but is this fluid overload or is this something else? Bedside ultrasound performed on the patient's lungs showed multiple dynamic air bronchograms suggestive of pneumonia, in this case aspiration pneumonia, and not suggestive per se of fluid overload. The patient was subsequently started on antibiotics. I think we all know it's been shown that DVT diagnosis with bedside ultrasound is extremely helpful, but it can also be diagnosed by the bedside clinician performing what is known as a 3-point bedside ultrasound exam. This study is really interesting because it showed just how bedside clinicians improve with experience and can achieve competency after a handful of exams. So what you see on the x-axis are the sonographers who were in the study, and on the y-axis, it's showing the number of exams that they performed. And as you get to the point where you're greater than 5 scans, what you find is that the operator no longer is generating either false negative or false positive exams, resulting in a sensitivity and specificity nearing 100%. So this is a case I was proud of. But of course, like many things in my life, I was proud of it, but at my own personal expense. I was the daytime attending taking care of this 69-year-old patient with COVID. They were intubated, they were receiving prone ventilation. And, before this case, I wondered just how useful is bedside ultrasound in a prone patient. Well, the overnight team was called to the bedside secondary to worsening oxygenation.
Think about it. All right, let's scan this one. Is it? Synchrony. Oh my, is that clot there? Did Dan Sweeney miss an ultrasound of a DVT?
So
I don't
this is the
believe
video
it.
I woke up to the next morning. Again, humbling for me, but really a prideful moment when you see trainees and colleagues that you work with showing you up with the technology that you've been trying to promote. Although I have to say, maybe I'm being a little snarky here, I thought my images were better, albeit the next day. So optic nerve sheath is another. So bedside ultrasound is not simply about the lungs and the heart, but it's also been extended to the nervous system. And in particular, looking at determining or estimating increased ICP. So the optic nerve is a part of the central nervous system. It's surrounded by CSF. Elevation in ICP is transmitted through the subarachnoid space, increased in the diameter of the optic nerve sheath. And this optic nerve sheath diameter is predictive of increased ICP in patients with traumatic brain injury. Optic nerve sheath has also been studied in the post-cardiac setting, and it's been shown to have utility in predicting neurologic outcome in these patients. So here's a case that I managed with Dr. Vigilani, one of our internal medicine residents. It was a case of a patient who had suffered a cardiac arrest. And what I'm showing you here is the patient's orbit with the ultrasound probe on the front, on their eyelid, shining back and highlighting the optic nerve. We subsequently measured that optic nerve, found it to be abnormally large, consistent with an elevated ICP. And this, in fact, was confirmed shortly thereafter with a brain MRI showing early herniation. Here's another neuro and POCUS case. This was one that we published, Gabe Wardy and I published. This was a case of a 54-year-old admitted to an outside hospital with subarachnoid hemorrhage. While they were in transit, he developed a severe and sudden neurologic deterioration requiring intubation. Upon arrival to the hospital, had a GCS of 3, an EVD was emergently placed, patient underwent coiling. But over time in the ICU, the EVD stopped working. It wasn't draining, there was no waveform. So it was very difficult to sort of monitor this patient. So a bedside ultrasound was performed, looking at the left eye, and I'll spare you the details, but I'm looking at the optic nerve here. Again, it was enlarged, making me concerned that there might be increased ICP in this patient who had a non-functioning or malfunctioning EVD. I then turned my attention to the right eye, and I wasn't able to really see the back of the eye secondary to this vitreous hemorrhage. So largely based on this exam and the fact the EVD wasn't functioning, the neurosurgeon took the patient to the OR, and this is from the OR note. New EVD placed for clotted malfunctioning catheter, elevated CSF opening pressure, ICP subsequently within normal limits, neurologic improvement followed the placement of EVD. And what I've just shown you is a case of Terson syndrome, where you have vitreous hemorrhage associated with a subarachnoid or ultimately any other cause of intracranial hemorrhage. So moving on to POCUS for the management of critical ill patients. So beyond simply diagnosing the critically ill patient. Albeit retrospective, this is the best study making the case for mortality benefit of managing critically ill patients with POCUS. It was, again, retrospective, 220 patients intubated and with shock. The study patients were managed in the ICU using limited echo-based protocol for fluid and vasoactive administration. They were compared to historic controls. And what they found were patients treated with this limited echo-guided therapy had actually a lower 28-day mortality and a reduction, interestingly, in the incidence of acute kidney injury, but no significant effect, interestingly, on duration mechanical ventilation. Limitations to the study, again, it was retrospective, historic controls. I have no idea whether those historic controls were 5 years prior, 10 years prior, so on and so forth. So part of providing quality care and ensuring procedural safety. And this is an area where ultrasound has proved invaluable. I think we're all aware of how ultrasound is helpful for line placement, but I would argue it's equally valuable with many other procedures, including paracentesis, which is associated with significant risk, especially in our high-risk patient populations. So in this example, this is Dr. Cadre, one of our former fellows, nicely identifying the inferior epigastric artery and vein before proceeding with a paracentesis. So besides identifying the inferior epigastrics before performing paracentesis, point-of-care ultrasound can help avert other potential procedural errors associated with paracentesis. And in this case, it's a case of a 54-year-old with hepatitis C end-stage renal disease. They were recently started on Lovenox and Coumadin, not for me to judge, secondary to concerns about vascular shunt patency. And they present now with increasing abdominal girth. So we placed an ultrasound probe on this patient over the abdomen, expecting to see ascites, but instead we saw this fluid collection, which was relatively superficial, and we weren't able to identify any bowel loops. This caused us to have pause with the paracentesis, went for a CT, and showed instead a rectus sheath hematoma. Estimating volume status is a daily challenge for clinicians in the ICU, and it has truly profound implications for management of these patients. Evaluating for ultrasound B-lines can be extremely helpful in these situations. This is really a great paper by Dr. Noble, in which she looked at 45 patients. They were all end-stage renal on hemodialysis. She performed lung ultrasound pre, midpoint, and post-hemodialysis. And at each step of the way, she counted, or probably her fellows, counted B-lines in 28 predetermined zones over the chest. And then they calculated the rate of B-line resolution. And what they found was that this was just a linear effect, such that for every 500 milliliters of volume removed, there was actually a decrease in almost 3 B-lines per patient. And this isn't to be taken lightly. B-lines in patients with end-stage renal disease, again, many of whom are in the ICU, are to be respected. Here's a study of almost 400 patients. A bilateral ultrasound exam was performed by nephrologists with 2 to 3 hours of training. They divided the patients based on their findings into mild, moderate, severe, or severe based on the number of B-lines. And what they found when they looked at these patients in terms of, or analyzed them with Kaplan-Meier plots, was that a severe bilateral ultrasound score was associated with an increased risk of death, and that actually 71% of the patients in the moderate to severe group had little or no other symptoms of failure. More recently, there's another approach to predicting volume status, something called the VEXIS exam. This is sort of the new kid on the block. And while I'm not completely sold on this management strategy, I give the researchers credit for building a scoring system that incorporates or integrates multiple ultrasound assessments. And again, I think this integration of multiple findings is really where the field is heading. So this was a post hoc analysis of 150 patients, about 700 ultrasound assessments. And they developed a scoring system to estimate venous congestion so as to identify patients who may be at risk for reduced organ perfusion. And this VEXIS ultrasound score incorporates, in addition to the IVC, which I'm not showing you here, it incorporates hepatic vein Doppler, portal vein Doppler, intrarenal Doppler. Now, I'll tell you that right off the bat, that hepatic vein Doppler is really something that can be mastered by the clinician at the bedside, and portal vein Doppler, I think, likewise. The intrarenal Doppler is a little more challenging, but honestly, it did not add much to this grading system. Those first 3 items actually really drove this grading system. And what they found was that severe venous congestion demonstrated or labeled as grade 3, where they had evidence of congestion on hepatic vein Doppler, portal vein, intrarenal Doppler, 2 out of the 3, was associated with the development of acute kidney injury. So I'd like to take this opportunity to emphasize the point that evaluation of the IVC is probably overutilized as a singular measure to estimate fluid responsiveness. I see this all the time in the ICU. Currently, many clinical care practitioners take an overly simplified approach to estimating volume responsiveness based exclusively on the size and collapsibility of the IVC. Many, in fact, categorize the IVC into these three groups shown here, showing either a small, fully collapsible IVC on the left, in the middle, a large but mostly collapsible IVC, or a large and mostly not collapsible IVC. The problem with this approach is there's just so many limitations or potential confounders when all you look at is the IVC for predicting fluid responsiveness. It depends on if the patient is spontaneously or mechanically ventilated. Depends on if they have on the presence or absence of right heart dysfunction, and it depends on the presence or absence of intra-abdominal pressure. Sorry about that. Okay, so unfortunately, when the IVC alone is studied as a predictor of fluid responsiveness in large trials, its clinical utility is proven to be limited. In this large study of over 500 patients, albeit ventilated patients, where it's thought this technique works the best, the take-home message was extremes in IVC diameter were predictive. And again, while this trial specifically was looking at end expiratory IVC diameter, the results have been found using other ways of measuring the IVC, percent change, so on and so forth. And what they found was that at the extremes, when the IVC diameter was less than 8 millimeters or greater than 28, this was predictive of either fluid responsiveness or unresponsive. However, unfortunately, 92% of patients fell into this gray zone, a range where the values could not lead to any particular conclusion about the patient's fluid responsiveness. This study further highlights the limitations, or I should say this figure further highlights the limitations of the IVC diameter in single-handedly predicting fluid responsiveness. 22% of patients in the study had a subcostal view, so they couldn't even examine the IVC. Only 8% of analyzed patients, again, had an IVC that fell into one of these extremes. And one of the reasons for this is that we're just not taking into account intra-abdominal pressure, which is present in this study in 30% of patients. And what it shows is that when you break the patients into those patients who had intra-abdominal hypertension, shown in the green, or the absence of intra-abdominal hypertension, shown in the blue, you get very, very different estimates of CVP. And in fact, when intra-abdominal hypertension is present, essentially this test is not useful. And again, you don't know that at the bedside, generally speaking, if your patient has elevated intra-abdominal pressure or not. So if I can't always depend on the IVC size to predict fluid responsiveness, what should I do? Back to this, you need to integrate your ultrasound findings, not only with all of your ultrasound findings, but also with your physical exam, with your data, your laboratory information. So you have static information, right? What's the LV function like? What's the RV function like? Are there B lines? Yes or no? Does the patient have pleural effusions? And there are other dynamic tests that you can employ, and our fellows are able to do some of these, of course, including fluid challenge. In our ultrasound course, we went over looking at variation of aortic outflow. And of course, there's also the passive leg raise. So this brings me to the idea of the integrated multi-organ bedside ultrasound exam, which has actually been advocated for quite a long time, since 1993. This was a study that was published looking at 150 consecutive patients in the ICU. And what they found was the whole body point of care ultrasound exam impacted therapeutic plan in 22% of patients. And they were able to identify a source of infection in 15% of those patients. So finally, here's a case I think that demonstrates the value of the multi-system integrated ultrasound of the critically ill patient. And this was a patient that, that I managed along with Dr. Mahindra, again, one of our internal medicine residents. This was a 58-year-old who presented with soft tissue infections and osteomyelitis. They went to the ward. They were diagnosed with septic shock, Staph aureus bacteremia, which was treated and believed to be resolved. And then after demonstrating altered mental status on the ward or on the general floor for approximately 12 to 24 hours, he suffered a cardiac arrest, received 1 minute of CPR with ROSC, and was subsequently intubated. And like so many of these cases, it occurred approximately at shift change. So the sign out that me and Mandy received was the vital signs are stable, and the chest x-ray was consistent with pulmonary edema and fluid overload, and nephrology had been contacted. The patient also was relatively anuric, and so nephrology was consulted. Again, working diagnosis of fluid overload. 1 hour later, though, Mandy and I were called to the bedside for hypoxia and hypotension. So what are we dealing with? So, taking this patient systematically, we looked at first their cardiac function in the subcostal view. What you see, you get a sense of a hyperdynamic heart. Now, again, this is one view, which many people say in the ultrasound world, one view is no view. But trust us, we had other images of the heart. We looked at the abdominal aorta, another potential cause for hypotension and shock. And what I'm showing you here is a normal sized aorta overlying a spine shadow. We then performed a pulmonary exam, and we looked at the right side. And what you see are pleural effusions, which sure could be consistent with or suggestive of fluid overload. But within that lung, and I'm not sure if my Zoom connection shows this, but there are dynamic air bronchograms within that lung tissue. We then looked at the left side and saw the same thing, fluid surrounded by consolidated lung with dynamic air bronchograms. Still, though, the patient had large ascites, and we wanted to be complete, making sure we're not missing a potential source. And this was I have to be honest, this was a tricky paracentesis. The patient had a few platelets. The pocket was not the easiest one to approach. And I thought to myself, okay, I'm just going to do this one. And Mandy said, can I do it? Or asked, can I do it? And sure enough, did a beautiful job. Here we are, where she's performing a paracentesis using real-time ultrasound, showing the tip of her needle safely away from patient's bowel. So in summary, it's important to integrate serial ultrasound findings across ultrasound systems to fully understand and manage the critically ill patient. The integrated multi-system point-of-care ultrasound exam improves, in my opinion, a clinician's ability to diagnose and manage the critically ill patient. It does not replace the physical exam, does not replace the need for other imaging exams. In fact, I think in my own personal experience over the last 15 years, I believe that I order the same number of exams, except I think I order better exams, more clinically indicated exams. And then when I talk to the experts reading these exams, I feel like having an understanding of point of care ultrasound allows me to have basically a better conversation with our colleagues. And ultimately, I simply cannot imagine managing a critically ill patient without this skill. So one final thought on what the experience is like for the critical care practitioner armed with the POCUS skill set. Well, first of all, the POCUS practitioner, in my opinion, is more attuned to the patient's clinical progress as they go through their hospital course, as you're frequently performing serial exams. And by the way, this is from the hospitalist literature, looking at how you perform a point of care ultrasound exam to help with the diagnosis. You then use that point of care ultrasound exam to help with therapeutic procedures. And then you can use that point of care ultrasound exam oftentimes to monitor and to detect whether the patient is improving or not. But I think this is also selfishly important, right? The point of care ultrasound practitioner, I believe, is simply more engaged in aspects of clinical discovery as it relates to the patient. So I really feel that for some of us, this is a large part of the reason we became doctors, because we accepted or were drawn to the challenge of figuring things out. And when you follow that pathway of the referral ultrasound, I think a lot of that discovery is taken out of your hands. And as a result, I just think it's less satisfying. I really feel for the house staff when I see them ordering studies and reaching out to consultants all the time and spending a large portion of their ICU time doing this. And again, this is not to say those other exams are not important, but I think with the point of care ultrasound, again, I think that you get closer to the discovery, so to speak, than if you don't have this technology. So I'd like to finish with some gratitude. This is Charlie Goldberg. And I showed up here 5 years ago and Charlie was just a kind, trusting person who basically gave me the key to the cars, so to speak. He allowed, I showed up at his office. I told him how I wanted to teach ultrasound to the residents. And he said, let's develop along with Simmerjot, we decided to develop a critical care ultrasound curriculum, which we've been now doing for 5 years. It's unique. I know this when I go and I talk, I interview patients for fellowship. I see that many of them coming out of internal residency do not experience a comprehensive ultrasound curriculum, and that's something we've had here for 5 years. And for our residents, this is something we're working on. Full disclosure, I'm not sure if it's official, but our aim is to provide our graduates with a letter describing their ultrasound training. Now, we're not in the business of certifying patients, but this is a letter that allows our graduates' next employer to be able to understand the ultrasound training that they've had. And this oftentimes helps with credentialing when they go to their next or first job out of training. For our critical care fellows, we offer a yearly course. And I should say that this course we've extended to other fellows across specialties. And this is also something that's I'm trying to iron out with the technology people on campus. But Jess Mandel has come forward with some money to support providing our fellows when they're on service with a bedside or handheld ultrasound device. And then we've extended our reach to Tijuana, where we actually started an ultrasound curriculum there. Roughly once a month, we go to Tijuana General and we teach bedside ultrasound to their house staff. And the fellows, including Mazen Odish, shown here, and also Jacob Bailey, are just two of the other people who helped with this process. And it's been a very rewarding experience, I think, for both the teachers and the learners. And so with that, I thank you. I welcome any questions. And in case you're wondering, in case you can see it, this irregular pleural line on this lung ultrasound is in a patient with scleroderma. So with that, I'll stop and thank you again.
Thank you, Dr. Sweeney, for that terrific presentation. We have a question from one of our chief residents, Dr. Siv. Great talk, Dr. Sweeney. In the study you cited where ER physicians increased their infectious diagnosis accuracy from 50 to 75% by adding POCUS, was there a standardized ultrasound practice all the physicians used? For example, a FAST exam? If so, what were they scanning?
Yeah, that's a great question. And I standing in front of you right now, I can't provide you with those details. What I was struck by, though, was just how advanced these providers were. As I alluded to, it is possible to diagnose appendicitis with point of care ultrasound. And these providers had reached the point where that was part of their practice. So what specifically that their systematic approach was, I don't know, other than to say that these were, it needs to be considered that these were very advanced practitioners. And so I don't think that, the mileage, so to speak, that we would see would be the same.
Thank you. And from Dr. Mandel, how do you recommend novices build their skills in POCUS? Sometimes it's challenging to build critical mass.
Totally. And I wish I had the answer. It's been studied, and they've polled program directors asking this very question. And the recurring themes are, number one, a consistent faculty that can teach, and also a faculty that values this, so that when you're rounding, every attending says, hey, what was the ultrasound on that hypotensive patient that you admitted? So that's one. Two is stuff. So, are there enough ultrasound machines? And I actually think, that's not a problem for us. And then I think the third thing is, if I can paraphrase what I was told when I was trying to learn how to surf when I moved to San Diego, it's time on the board. And I would say that is the same with ultrasound. It's time on the Ultrasound Pro. I think it's really important to scan all of your patients when when they come to the ICU at least once, and to really establish in your head what is normal. And to that end, some people have seen how I rarely change the settings of the ultrasound probe when I'm scanning a patient, in part because I want to really know what normal looks like. And if I see something abnormal, I've removed that variable of, well, is it because of a setting? Is it because of a different probe? And so again, emphasis on, you've got to do this, you've got to do this consistently.
Thank you, Dr. Sweeney. From Dr. McCutcheon, how important is variation in the ultrasound device in learning and applying these exams?
Really not much. All the machines have most of the, well, I would say there's a pretty firm line between the handheld and the freestanding ultrasound machines, and then, the $200,000 Philips machines that are in the Echo Lab. But amongst those freestanding machines, they all have the same functions, and they all have the same settings that you basically need to learn how to optimize, which include, gain, depth, frame rate, so on and so forth. So I don't believe it's that much of an issue, quite frankly. Now, the handhelds, I do believe there is something of a step down on quality of that imaging. But I think in some ways that's overcome by the fact that if the ultrasound is in your pocket, you're more likely to scan more often. So I think you get added value in that convenience.
Thank you. And from Dr. Farkandapur, thank you, Dr. Sweeney, for that excellent talk. Are there any concerns from a medical, legal, and surrounding point of care ultrasound? For example, potentially uploading an image with an incidental finding that wasn't addressed.
Ali, you're great, but you're troublesome. So I actually have a slide on some of the legal ramifications of bedside ultrasound. And so let me begin with I teach at one of the national courses where one of my colleagues is married to a lawyer, and she actually has a fair amount of data showing that people get into legal trouble actually when they don't perform bedside ultrasound. So that's the first thing. Now, in terms of those incidental omas, one of the things that we teach, and Ali, you've heard me say this multiple times, you own that image, you can't unring that bell. So if you see something that doesn't make sense to you, the obligation is on you to figure that out. And I have, depending on the time in my career and what the technology was like, I have done things like taking my cell phone and taken a picture of an ultrasound image and sent it to radiology or to a cardiologist. I've wheeled the machine down to radiology to show them my images. So the exact ramifications of uploading an incidental OMA, I don't know. What I do know is that people have gotten into trouble for not performing bedside ultrasound. And two, I think it's really important to stress with learners that you own that image, everything on the screen, and that you're responsible for what's there. So thanks for the question, Ali.
Terrific. Thank you, Dr. Sweeney. If there are no further questions, I want to thank you again for this thought-provoking and interesting presentation. And I hope all of you will join us for Grand Rounds again in 2 weeks. I just want to remind you that we will have a holiday from Grand Rounds next Wednesday due to Thanksgiving. Have a great day, and thanks again for coming.
Thank you.